So I would request Dr. Jatinder Singh Bhalla to start off our session with his talk on rise in intraocular pressure during and after cataract surgery.
Good morning, everyone. At the outset, I'm thankful to Dr. Namrata Sharma for giving me this opportunity. I'm going to talk on rise in intraocular pressure during and after cataract surgery. IOP, there is a decreasing effect on IOP of cataract surgery, which lasts for about 3 to 6 months, and this is to the tune of 1.1 to 2.5 millimeter mercury for at least 6 months post-operatively. But IOP may also increase in the early or late post-operative periods, and this is particularly significant after congenital cataract surgery. And there is increase in IOP during the first 24-hour cataract surgery, which is a major post-op complication. This may initiate at 2 hours with a peak at 6 hours and last for 24 hours. Why it is important is because it may not only cause pain, corneal edema, but it may also cause complications like NAION, retinal vascular damage, and patient may complain of decreased visual acuity. And the exact mechanism why it rises is probably multifactorial. Why IOP rises during cataract surgery? For a typical eye with an anterior chamber depth of 3 mm, the volume of anterior chamber is just about 0.2 ml, and the posterior chamber volume is even lesser, that is 0.04 ml. So this makes combined volume of 0.24 ml. That is, just imagine, it is equivalent to just 6 to 8 drops in which we have to remove the cataract and insert the IOL without causing damage to the ocular structures. And what is the relation between the bottle height and the intraocular pressure inside the eye? If we calculate 15 centimeter bottle height above patient eye level is equal to 11 millimeter of mercury of intraocular pressure. So if we have bottle height of 100 centimeter, this induces pressure, IOP pressure of 74 millimeter, and if you have bottle height of 90, it causes IOP of 66 millimeter of the mercury. So when surgery starts and you have infusion level at 100 centimeter, it causes 74 millimeter of the mercury, and this is very high pressure. So when you go in foot position 2, what happens is then there is some aspiration also, and this will cause IOP to decrease. But if you go in just foot position 1, the IOP will be very high, which may be hazardous in patients with moderate to severe glaucoma. And then another important entity is mean arterial pressure and mean ocular perfusion pressure. Mean arterial pressure is diastolic blood pressure plus 1/3 of the difference between systolic and diastolic. And mean ocular perfusion pressure is 2/3 of this mean arterial pressure minus intraocular pressure. So if you have systolic of 120 and diastolic of 70, then the mean arterial pressure is 87 and mean ocular perfusion will be 38 millimeter of mercury. And so if you go with bottle height of 100 millimeter of mercury, 100 centimeter, which is 74 millimeter of mercury, what will be the mean ocular perfusion pressure? It will be 2/3 of 87 minus 74, that is minus 16. That means during this bottle height of 100 centimeter, your ocular flow will completely stop during this part of the surgery, and longer you stay at this bottle height, particularly in patients with compromised blood flow in moderate to severe glaucoma, it is going to be really hazardous, and you may have done excellent cataract surgery, excellent phaco surgery, and next day you find that the patient's vision is gone because of this high intraocular pressure which you have maintained for a longer period of time. Another important condition is acute intraoperative rock-hard eye syndrome. This may particularly occur in hyperopic eyes during uneventful phacoemulsification, and what patient presents is with a shallow AC with absence of suprachoroidal effusion, and this may occur hours after the initial surgery, and this is due to inappropriate movement of the BSS via the zonular fibers behind the lens. So so what we can do with this increased bottle height, we have another mechanisms like Alcon Centurion has active infusion fluidics, which really takes into account, because here it is not gravity dependent. So you can do the surgery at a target pressure of 20, 30 or 40 millimeter of mercury without compromising on the phaco parameters like flow rate, vacuum, etc. Active fluidics technology makes you operate at a target intraocular pressure and also maintain surgeon selected target intraocular pressure. And so this active fluidic technology is very important. It not only provides excellent chamber stability but more natural IOP targeting. IOP control is there in other phaco machines also. Johnson & Johnson has come with on-demand fluidics. Stellaris, Bausch & Lomb has adaptive fluidics, and this helps to stabilize intraocular pressure. So an important parameter which we used to neglect is now being taken care of in the advanced phaco machines. Then there are the intraocular pressure may rise post-cataract surgery. This can be classified into open angle and closed angle glaucoma. Hyphema, if is significant, may cause both open angle and secondary glaucoma due to trabecular meshwork obstruction by RBCs, or PAS may form. So what we have to do is, if it is very mild, then we just give anti-glaucoma medications along with the topical steroid drops. But if it is high, particularly in patients, and you find that the intraocular pressure is particularly high, about 35 to 40 millimeter mercury, maintained for a longer duration, particularly in patients with mild to moderate glaucoma, then this is hazardous and you may have to do paracentesis or AC wash. Uveitic glaucoma can occur particularly if you patients operate cataract surgery in patients with uveitis. It can cause open angle glaucoma due to trabeculitis or secondary open angle glaucoma, particularly in you do cataract surgery in patients with heterochromic cyclitis. And angle closure can occur from if you are doing in patients with rubeosis iridis. So UGH syndrome is no longer a significant entity, particularly we have shifted from AC IOLs, but it can occur if you are implanting hydrophobic IOLs in the ciliary sulcus, so UGH syndrome can still occur. This is another important entity. If you have left behind some epinucleus, nuclear fragments in the anterior chamber, then you can have rise in intraocular pressure. Steroid-induced glaucoma is something which we neglect, cataract surgeons neglect. If you are giving steroid for long duration of time, then you find that everything is okay, but the intraocular pressure is high. This may be due to entity of steroid-induced glaucoma. Viscosurgical devices have to be completely washed out from the anterior chamber, particularly the dispersive is difficult to remove, although cohesive comes out instantly. So what we can do is a very good technique advocated by Uday Devgan. This is called angle sweep. Just perform an angle sweep with injection of BSS via 27 gauge blunt cannula, and this can release the viscoelastic from the angle of the anterior chamber, and then you can easily aspirate it out. I won't go into details of capsular block syndrome. You find that suddenly the intraocular pressure postoperatively is high, and there is unexpected myopic over refraction because this is fluid accumulation behind the lens, and the IOL comes anteriorly and the capsular excess margins blocks it. So treatment of glaucoma after cataract surgery can be done with topical and systemic aqueous suppressants along with steroid drops, and in rare cases you may require, if there is pupillary block, laser iridectomy for pupillary block, and other surgical measures like AC wash, etc. may be required. So elevation in IOP may occur early or late in the post-op course and can be associated with either open or closed angle, and there it is multifactorial. Thank you everyone for your kind and patient hearing, and I take this opportunity to invite all of you to the annual DOS conference, which is going to be held from 10 to 11th February in New Delhi. Thank you. Can I cover second talk also?
Yeah. Which is the second topic? Yeah.
So I'll just cover my second talk also. This is relevance of fixed dose combination in managing glaucoma progression. We all know that glaucoma is a leading cause of irreversible blindness, and as far as causative cause of blindness, it is second only to the cataracts. And in India, about 12 million people are affected, and nearly 1.2 million people are blind due to glaucoma. In open angle glaucoma, as we all know, medical therapy is the most frequently used intervention for lowering intraocular pressure, but combination of agents are often required to achieve and maintain target intraocular pressure. So the first drug which came into vogue for glaucoma management was in 1875, it was pilocarpine, almost 100 years later, we had beta blockers like timolol. Then in late 90s, we had prostaglandin analogs and alpha agonists. Then combination drugs started appearing, like we had combination of prostaglandin with timolol, then combination of alpha agonist with timolol in 2005. Now we have non-beta blocker combination like alpha agonist brinzolamide with brimonidine. So there are both prostaglandin combination, there is combination with beta blocker and non-beta blocker combination. Uncontrolled intraocular pressure is a risk factor for the development and progression of glaucomatous optic neuropathy. And each 1 millimeter decrease in intraocular pressure reduces the risk of progression by close to 10 to 20%. Various studies like EMGT said the reduction of risk is about 10% per millimeter of mercury, whereas United Kingdom glaucoma treatment study as summarized it as 19% reduction per millimeter of mercury. So it is between 10 to 19% per millimeter of mercury reduction. And several international guidelines, including NICE guidelines, European Glaucoma Society, CGIG, International Council of Ophthalmologists, even Japan Glaucoma Society has advocated use of combination therapy in the management of glaucoma. Why issues with multiple medication is problematic is because there are compliance issues. Patient may not remember to put the drops if you are prescribing multiple, particularly 2, 3 or 4 drops. There is increased preservative exposure. And if we compare fixed combination with multiple drops which are to be put, you find that if multiple drops are put, number of eye drops instilled are much more. There is washout effect if you put second drop immediately after putting the first drop. There is less tolerability. Convenience of administration is not there. Compliance and adherence issues are there. And there is more exposure to preservatives rather when you give fixed drug combination. And preservatives used in topical glaucoma medication have definitely toxic effect on the ocular surface, so much so that prevalence of OSD is estimated to increase up to 50% in glaucoma patients under multiple medication treatment. And what is maximum medical therapy? It is the use of 3 or more different classes of anti-glaucoma agents to achieve a maximum lowering of intraocular pressure. But now it is possible to give just 1 or 2 drops with 3 or 4 classes of drugs, and that is with the help of just fixed drug combination. And these are the IOP lowering regimes of 3 to 5 medications. Imagine you can give 3 medicines with just 2 bottles, or you can give 5 medicines with just 2 bottles. It is possible because of multiple fixed drug combination available. So instead of counting the bottles, it makes sense to count the drops. And it is important because as far as patients' exposure to the preservative is concerned, if you decrease the number of bottles, your number of drops also decrease and the preservative exposure decrease. So these are the list of currently available fixed drug combination. You have combination of dozolamide with timolol, brinzolamide with timolol, or prostaglandin with timolol, or brimonidine with brinzolamide. And now we have advent of triple drug therapy with just in 1 bottle. And these are the published studies of triple fixed drug combination in various parts of the world. These are in peer-reviewed literature. And we are fortunate to have recently a triple drug combination has been developed in India for glaucoma, and trials have been conducted at multiple centers with this triple drug fixed drug combination. And how it is going to help us? We are definitely going to have 3 classes of drug in 1 bottle. So there is a reduction in total number of drops, improving compliance, decreasing washout effect, reducing the risk of ocular surface damage to exposure to preservatives, and there is ease of adding an additional class of anti-glaucoma drug to this 1 bottle if we so require. And this combination is brinzolamide, brimonidine with timolol. And how it is going to affect? It is acting at multiple mechanism of action. Brimonidine is going to increase uveoscleral outflow. Timolol is going to decrease aqueous humor production. Brinzolamide is going to improve ocular blood flow, and brimonidine will have neuroprotective role in optic nerve in glaucoma. So thus 1 drop is going to have multiple mechanism of action, and these are first Indian clinical trial on triple fixed dose combination which has been conducted, combination of timolol, brimonidine and brinzolamide, and these were the study objectives where the primary endpoint was changed from baseline in intraocular pressure, and secondary objective was to assess the efficacy, safety and tolerability of triple combination of this fixed drug combination. So the screening was done, and then baseline intraocular pressure was estimated at day 0, then second week, 6th week and 12 weeks. And what we found was that there was significant reduction in the intraocular pressure to the tune of about 10.5 millimeter of the mercury, and this decrease was statistically significant. So when the evaluation of tolerability and efficacy was also estimated, it was found that the proportion of ocular adverse events was just 7 out of 17, and the proportion of non-ocular adverse effects was 10 out of 17, and these were not significant. Ocular side effects were only dry eyes, burning sensation, redness and itching, and these were just mild to moderate. So this reduced preservative has definite advantage with triple drug combination, and this is if the current unmet need says if the disease keeps on progressing despite treatment and there is IOP fluctuation and there is patient non-adherence, then this fixed drug combination with triple drugs can help to address this current unmet needs. So I think that we are in for real significant revolution as far as medical management of the glaucoma is concerned. Imagine if you have this combination being given and still you want to give one more drug, the prostaglandin analogs are still available at your command. Thank you everyone for your patient hearing.
Thank you, sir, for the masterly presentation. Actually, one of the important things that is coming up is the dropper technology also, no?
Yes, sir.
Because the volume of drop that goes into the eye is to be minimized.
Exactly.
To be able to minimize the side effects.
Yeah, the uniform drop size, that is very important, because what happens is the capacity of the conjunctival sac is limited. It is just about 15 to 20 microliter. So if the drop size is bigger, what is going to happen is it is going to spill over and cause the prostaglandin associated periorbitopathy side effects like pigmentation of the eyelids, of the eyelashes. So I think, and there is wastage also as far as financial aspect is concerned. So it is important that the drop size should be good, but then we also have to remember most of these patients are old with having arthritis problems, and it is not possible for them to just instill straight away with one shot right into the eye. They'll spill all over the eye without putting the drop going inside. So that is another important aspect which we really neglect, whether patients are able to put the drops themselves or they need some help to be able to put.
So another major disadvantage with this multiple drug system in one drop, one bottle.
So the major disadvantage is you cannot start the patient with this fixed drug combination of double or triple drug. Only if the patient is uncontrolled on two drugs and you have to add the third drug.
In those cases,
yes.
If any side effect appears, we cannot label which drug causes a particular side effect.
Yeah, that one problem will remain. But if you find that the patient is already on brimonidine and timolol and you have to add, and there was no side effects, you just have to add brinzolamide, then this drug can be given because the patient was not having any side effect to the earlier two drugs. And if it is the side effect is occurring to the triple drug combination, then you straight away know it is because of the brinzolamide. Then you can stop it.
And one of the important things about medical management is that not all drugs are equally effective in all patients.
Exactly.
So if we are starting off with 3-molecule combination or 2-molecule
No, that is not advisable. Starting with fixed drug combination is never...
It's not going to be the right thing
No,
to do.
no. Always start with single drug. Then if patient wants, you have to add second drug or third drug, depending on whether the patient is a fast progressor or slow progressor. That way you can take a call, sir.
So have to keep the patient with us for a long time. Convincing the patient that it is going to be a lifelong therapy.
Exactly.
Is going to be the challenge and should be taken systematically.
Right. Thank you.
Sir, regarding the first talk, I had a question that whenever we are having a situation where PC rent is there, then we tend to give more and more injectable viscoelastic. And that is something that needs to be, I think, control.
That should be avoided because most of the
Because,
viscoelastic you are going to inject is going through the PC rent into the vitreous. And that will cause not only inflammation, it is going to cause significant increase in intraocular pressure. And one thing incidentally we have noticed is most of the cataract surgeons, once they find next day clear cornea, good vision, they don't check intraocular pressure. I make a strong case for checking IOP at least by NCT. Or if you are not, you don't have NCT, do this thing, applanation tonometry. You must check pressure at least on the first day, along with checking the vision and slit lamp examination. It is a must because many a times we miss that the patient was having increased intraocular pressure, and later on, when the patient comes with the problems, then suddenly we start suspecting whether the patient was having glaucoma pre-operatively, which was missed, or it occurred, the rise in intraocular pressure occurred after the cataract surgery.
Yeah.
Right.
So that, especially in the posterior chamber and PC rent cases, we have to be careful to use minimum viscoelastic and to use hydration as far as possible to form the chamber.
Exactly.
So if the wound is good and all, we understand the wound mechanics, we will be able to do that.
Post-operatively, any rise of intraocular pressure is significant.
Yes, sir.
Thank you, sir.
Thank you, sir.
Yeah, please. I would invite Dr. Tiruvidi Sai Yashwant. Sai Yashwant is there? Dr. Sai Yashwant, LVP. Why is it? Yeah, I can see Yashwant. I think, are you ready with your presentation?
Any present
Okay,
is ready?
you want to do
With
the
respect
next
to the seniority.
presentation.
Please come.
Dr.
Please come.
Sumita Mahapatra is ready? Please come, madam. Madam will be presenting on the importance of evaluating macula in all stages of glaucoma, early to severe.
Yeah. Good morning, everyone. I thank the scientific committee for this opportunity. I am going to talk on the macular evaluation in all stages of glaucoma from the early to severe. Traditionally, all the glaucoma patients are evaluated by evaluating the optic nerve head and circumpapillary retinal nerve fiber layer. And in the perimetry side, it is always 24-2 or 30-2 begin with. But currently, we are seeing that the glaucoma can affect the macula in the very early stage. I don't have any financial disclosure to make. So, why should we study macula in glaucoma? We know that the main pathology in glaucoma is the retinal ganglion cell death. The retinal ganglion cells are dying, which is reflected in the loss of the retinal nerve fiber layer and itself the cupping of the optic nerve disc. And majority of the entire ganglion cell population reside in macula, which is plus minus 8 degrees from the center of the fovea. So, though the macula area is only 2% of the total retina by area, it contains about 50% of retinal ganglion cell of the entire retina. This signifies its importance, and we have to think about the quality of life of the patients. Most of the quality of the life of the patients decline in glaucoma because the damage to the macula. The patient is not bothered about his nasal strip or paracentral scotoma. What he is bothered is about loss in central vision, like loss in contrast sensitivity, loss in chances of fall, difficulty in driving, difficulty in reading. All those are functions of central vision. So we should be careful about evaluating the central vision function in case of glaucoma. So another importance of macula is that the RGC body itself is 10 to 20 times larger compared to the nerve fiber layer, which are their axons, and it is at macula, it is multi-layered. So it is thicker at the macula, and any change is easily detectable at the macular level. And variation in the ganglion cell is very small at the macula, and it is another important point is that it is less affected by the factors like size and tilt of the optic disc, parapapillary atrophy, which always affect the retinal nerve fiber layer. So why is macula often overlooked in previous years? Because of certain misconceptions. We were traditionally using the 24-2 field test, which were only having 10 points in the central 10 degree. It was the central vision was not well demarcated, well differentiated in case of perimetry. So we were missing the early changes. And macula in macula, we believe that the central vision is preserved till late, so it is not available, not affected in the early stage. Actually, that is a misnomer, because at the center, it is 6 to 7 layers thick. Till the last layer of the ganglion cell is gone, the defect will not come on the perimetry. So we used to think that it does not affected in the early stage, but it usually simultaneously or earlier than peripheral vision, macula, central vision gets affected, which we can know by the 10-2. And due to the advent of the newer swept source and SDOCT, we can now segment the proper segmentation of the macular layer, and we can know that changes also occur in the macular area in glaucoma. So if we do only 24-2, we can miss certain 10-2, certain field defect which is well delineated in the 10-2. So it should be done if we suspect something is happening at the center. That I am coming later on. The macular anatomy, few knowledge about the macular anatomy is important. The actions of the retinal ganglion cell, which from both above and below the horizontal raphe arch above the macula, and they come to the superior and inferior part of the disc, which are usually vulnerable to glaucoma defects. And here you can see that the superior fibers, they end in the temporal area, whereas the inferior zone, they are entering in the inferior macular zone, inferior zone of the retinal disc, which is at the most vulnerable. So inferior fibers are more at risk. And here the Donald Hood concepted a model, and here it is told that the less vulnerable area inside the macula, it comes to the temporal region, which is least affected due to the papillomacular bundle, and the more vulnerable area, it is coming to the inferior retinal area, and it lies between the 295 and 322 degree on the inferior part of the disc. And damage to the fibers passing through the superior vulnerable zone and inferior vulnerable zone, which is not in the macular vulnerable zone, that causes nasal steps, arcuate scrotoma and peripheral field, and whereas the fiber coming from the macular vulnerable zone causes paracentral defect. And moreover, progression in case of glaucoma is also we can judge better in case if you do the ganglion cell analysis, because after the thickness reaches the 40 micron level, there comes the flow effect in case of retinal nerve fiber layer, and further decrease in the field we cannot check by this retinal nerve fiber layer analysis, where glaucoma ganglion cell analysis is working till a later stage. So in case of advanced glaucoma, to know the progression also, it is very helpful. And macular OCT measurements have a high reproducibility in the advanced stage also, they do not vary much. So for this reason, in the diagnosing and progression in case of advanced glaucoma macula fielding, the ganglion cell analysis is very much important. So in certain special situation also, the macular ganglion cell analysis is very important. Morphological changes in the optic nerve like tilted disc, stretching of the circumpapillary retinal nerve fiber layer, and peripapillary atrophy can cause OCT artifacts if we do only RNFL thickness. But in the ganglion cell layer is less affected by those things. And in myopia, there is stretching of the retinal nerve fiber layer, and there is temporal displacement of the retinal nerve fiber layer peak, which will cause artificial thinning of that area, and that will cause the red disease, which can be avoided if we do the retinal ganglion cell, particularly in myopic patients. And optic disc hemorrhage is always associated with more macular involvement. And normotension glaucoma, paracentral defects are more common. So in those patients also, it is very helpful to examine the macula by the ganglion cell analysis. And here are the few examples in which you can see that there is red disease occurring because there is temporal shift of the retinal temporal shift of the peaks, and it is due to the stretching, it is very thinned out and causing the red disease. And in early NTG also, even if you see one spot in the 20/2, we should think that the center vision is threatened, and we have to order a ganglion cell analysis in those patients. And there are certain limitations with if we do only ganglion cell analysis, because various optic neuropathy, including compressive and ischemic neuropathy, can cause defect in the macula. But if we see carefully this, there is a temporal raphe sign, which is very specific for glaucoma. But in case of other neuropathies, they will have this type of ganglion cell defect, and if we see carefully, then the temporal raphe sign will give us some help. that it is a glaucomatous defect. So to conclude, the macular evaluation is very important for early diagnosis and monitoring glaucoma progression, particularly in advanced cases due to the floor effect if we do only the RNFL, and it cannot show more for progression, and it is particularly helpful in certain, including certain important conditions like myopia, which is very common coexistent with the glaucoma. And early glaucoma patients with macular damage should be treated more aggressively to present visual disability, because our glaucoma patient need their central vision very much. A slight amount of difficulty in the reading or driving will cause degradation of their quality of life. So we should be carefully evaluating the macula. And next question comes whether we should evaluate macula in all the patients. Should we do the 10-2 in all the patients or 24-2 to start with? If we see any single point of, with having a black square in the 20/2, that is indicate that that area is going to affect, and we have to order a 10-2 simultaneously. If we see any defect in the inferior vulnerable zone, inferior arcuate area, then that is also should indicate us that macular area is going to be involved, and we have to treat aggressively. So if you keep these things in our mind, then central vision of our elderly patients will not be affected, and quality of our life of the patients will be maintained. Thank you for that.
Madam, where you will advise this macular OCT for the glaucoma? Is it for early stage or advanced stage?
In early stages also, the macula is being involved, though we are not seeing it or recording it due to the either the segmentation error or this proper segmentation, and we usually do 24-2. But if we are suspecting that central area is going to be involved, like if the patient complains of, we send the patient for visual recording, he will have 6/6 vision, but he will have difficulty in contrast sensitivity, he will have difficulty in driving, he will be going on telling us that these things, we will record the vision 6/6 and we'll tell them nothing is happening, you go away, it is due to cataract, but it may be due to macula. In such patients, we have to order that macula evaluation. And another thing, one square spot in the centermost 4 points, if it is involved, then that much of ganglion cell is lost, because at the center ganglion cell is 6 to 7 layers thick. So if for one black spot to appear, normally 130 to 140 ganglion cell have to be lost for that one particular spot. So in that case also we have to order another 10-2. It may be difficult for the patient in the same setting. Either we can do give a gap of 30 minutes, or in the next visit we see the central vision, but that is very important, because that is what is bothering to the elderly group.
24-2.
24-2 is routine.
10-2.
10-2.
But in between there is 24-2C is also available.
And that is coming, but nowadays recent reports are not very much encouraging about that, though they see certain points. And in that also, if the 24-2 see that they are adding 10 more specific points in that area, which are more prone for glaucomatous damage. If we see any defect in that, then again we have to do the 10-2, because 10-2 elaborately examines those areas.
Great, madam. Please stay on in the dais. Next, we would invite Dr. Anita Mishra. Madam is available. She will be speaking on cataract surgery with trabeculectomy.
Thank you, AIOS Scientific Committee, and thank you, Dr. Jatinder Bhalla, for making my work easier. And thank you, Sumita ma'am, my mentor. So cataract and glaucoma go hand in hand, because both are leading causes of blindness and visual impairment. Being age-related, they frequently coexist, and presence of one impairs the other because of lens-induced glaucoma or glaucoma surgery accelerating cataract. So in a situation when there is any type of glaucoma, open or narrow angle, pediatric or secondary, with some amount of cataract, the decision to switch over from medical to surgery depends on the coexistence of cataract and glaucoma, when there is a pressing need to either control IOP or remove the visually significant cataract, or both. Now, in a situation with primary open or closed angle glaucoma with some amount of cataract, when the glaucoma with medical therapy or laser therapy is failing in lowering IOP, or there is rapid progression of glaucoma, advanced glaucoma at presentation, or non-compliant patient or inability to afford medical therapy, or in a setting of angle closure when iridotomy fails to control IOP, one may contemplate surgery. Now in pediatric glaucomas or secondary glaucomas like pseudoexfoliation or traumatic glaucomas, we can do a mitomycin augmented trabeculectomy with combined or sequential cataract surgery. Now when the cataract is more than the glaucoma, that is cataract is visually significant or a complicated cataract, then we can think of a two-staged or sequential trabeculectomy following the cataract surgery if there is a mild glaucomatous damage or the intraocular pressure is well controlled with medications. Now combined cataract surgery and trabeculectomy in the same sitting can be done even if there is incipient cataract with mild visual impairment and the glaucoma is uncontrolled and progressing, because after glaucoma surgery the cataract worsens. So it is advisable to remove the cataract even if it is not significant. So what happens? When in an open angle you remove the cataract, some anatomical changes are there in the eye from lens removal, and there are some biochemical changes due to irrigation of the trabecular meshwork. So some amount of IOP is lowered, but in a closed angle, the cataract surgery is effective in all stages of angle closure disease by alleviating the pupillary block between the lens vault and the pupil. So it opens up the iridocorneal angle in any stage of angle closure glaucoma if you remove the cataractous lens. There are various studies. Some have mixed results, some advise one procedure, some advise a sequential, but the landmark studies are Moorfield Safe Surgery System, which states that combined surgery is effective in lowering IOP, but carries the risk of post-op complications and failure, and these causes of failure can be reduced by adopting the safe surgery system of trabeculectomy. The ocular hypertensive treatment study, it has mixed results on the combined surgery or sequential surgery. Now, EAGLE study is one definitive landmark surgery for angle closure glaucoma with cataract, and in the long run, the lensectomy group had lower IOP, were on fewer medications and required fewer interventions to control IOP in angle closure glaucoma after cataract surgery. So of the various surgical options like cataract alone, trab alone, combined surgery or a sequential surgery, in a combined surgery we can do in a single site or two sites for both the surgeries, and in sequential we can do either surgery first and the other later. Now there are various advantages and disadvantages of a sequential surgery, but mostly it depends on the surgeon's clinical expertise and the surgeon's requirement about the visual prognosis. Now in combined surgery, again, we have a single site and a two-site surgery. Though the single site surgery saves the patient's and surgeon's time and resources, and it is technically easier, but in the long run, the two-site surgery has better post-operative IOP control and less need for adjunctive glaucoma medications. Again, the decision depends on the surgeon's expertise and the patient's compliance and the stage of the glaucoma and the stage of the cataract. And these are very customized surgical decisions by the surgeon. So in pre-op evaluation, in the setting of a cataract, we have to see the macular potential, maybe by a potential acuitimeter, and definitely look out for any zonular dehiscence or poor mydriasis, so that to keep your surgical armamentarium and instruments ready to avoid any post-op or intra-op surprises. Now, combined surgery can be single site, like in MSICS with any type of incision, and you can do the trab inside the flap. Then you can do sclerectomy by punch or scissors and close the flap by either interrupted or releasable sutures. And in a two-site surgery, First, you do the clear corneal temporal phaco, and then you move on to the superior side to do a trabeculectomy. It is definitely better to do the cataract surgery first, because if you do the trabeculectomy first, then in a setting of hypotony, it is difficult to remove the cataractous lens. But some surgeons vary. Now, post-operatively, follow-up is very, very, very important, because you have done 2 surgeries in one setting, or maybe sequential, but you have done 2 surgeries. So look out for snuff out phenomenon. The early post-operative complications or the late post-operative complications of either the cataract surgery or the trabeculectomy surgery are magnified. So you have to be very particular on first day, on 1 week, and after 3 months, and any time to look out for any complications of either of the surgery. So other types of combined surgery apart from trab are glaucoma drainage devices, mostly in complicated uveitic or neovascular glaucoma or previously failed trabs, the express mini shunt, and now they are using some antifibrotic agents apart from mitomycin C like collagen implants or bevacizumab for better bleb outcome. So to conclude, whether to plan a combined cataract and trabeculectomy surgery or to do one surgery first and then do the another later is best left on the clinician's expertise and the patient's requirement. It is important to decide whether the cataract or glaucoma is more advanced and whether you are doing a single site or a twin site surgery in a combined one, results in the long term are similar. So if you are doing a sequential surgery, typically the cataract surgery is done first to decrease the amount of post-surgical inflammation. But if you see a patient where trabeculectomy has already been done, but the pressure is not controlled, you can delay the cataract surgery for 6 to 12 months to improve the long-term survival of a previously functioning filtering bleb. Now, when you are contemplating to do a trabeculectomy, which is more urgent, then in the same sitting, you can remove any amount of cataract because the cataract progresses after glaucoma surgery. In ocular hypertensives or in open angle glaucoma, the role of isolated cataract surgery is debatable and it is left to the clinician's choice. But in angle closure glaucoma, definitely removal of the cataract is beneficial in all stages of glaucoma by elevating the pupillary block. So with this I conclude that for a fair surgery, we can't put all patients in the same platform. It has to be customized and individualized according to the surgeon's choice and the patient's visual requirements. Thank you.
Now I invite Dr. T. Sai Yashwant. Is he ready now? Okay, not yet ready. Dr. Pranamita Pujari for speaking on releasable sutures in trabeculectomy, what all a surgeon needs to know.
Good afternoon, everyone. I am Dr. Pranamita Pujari and my topic is releasable suture. So after 55 years also, trabeculectomy is still the gold standard in glaucoma surgery. But most of the complications of trabeculectomy are inherent to the anatomical basis of the technique and these are beyond the surgeon control. They are fibrosis and healing. So on the OT table, surgeon tried to balance two conflicting goals. The scleral valve sutures should be loose enough to permit aqueous-humor outflow, and at the same time it has to be tight enough to prevent post-operative hypotony. And all the complications of trabeculectomy, if you see, they are attributed to two basic problems. Either there is overfiltration and consequent hypotony, or there is underfiltration or consequent failure. And this complication can be mitigated if flow through the scleral osteum can be regulated. So it tightly sutures scleral flap in the operating room, and post-operative titration of the filtration by manipulating the suture is the key answer to the successful outcome of trabeculectomy. So this can be done by 3 ways: laser suturalalysis, adjustable sutures, and releasable suture. The problem with laser suturalalysis is you need a machine, you need a contact lens, then can be trauma to the conjunctiva in the first post-op period, and there can be problems of visualization of the suture if there is thick inflamed tenon tissue. In adjustable suture, the problem is you have to fish under the conjunctiva, so there is chances of buttonholing also, and immediate post-op period episcleral tissue proliferation occurs, so suture visibility can be an issue. So the answer is releasable suture. They are nothing but interrupted externalized scleral flap suture with slip knot. So they allow you to post-operatively titrate the filtration and reduce complication also. The advantage is you don't need a machine, you don't need a lens. Suture visibility is not irrelevant. You can see the suture even if you don't need, look through the conjunctiva to see the suture. There is no pain while removal, and if you are putting suture while doing trap, so the learning curve is also easy. The techniques are different technique. There is Wilson techniques where mattress type scleral flap suture is externalized with a knot on the cornea, and postoperatively the suture can be cut or removed. This is Scene technique, another technique, while the scleral flap suture with a releasable knot is passed through the conjunctival bleb, but the problem is the subsequent wound leakage when you release the suture. Now this is the Cohen and Osnott technique. Here the suture is first passed in a reverse fashion through intact sclera through the triangular flap. Next the suture is passed through the center of the cornea, center of the base of the triangular flap. Then a fourth throw is performed. Then after that suture is adjusted to the desired tension, and the approximately 3 mm the suture lies freely on the cornea. Now the modification is Kolker's technique. If you see, the steps are same, but after putting the suture is passed back through the cornea to the cornea laterally. So the suture end doesn't lie flat on the cornea, so you don't have any corneal thing coming or wind seal. This keratopathy doesn't occur in this procedure. So what most of the surgeons do also, they 10-0 monofilament suture. You have to put first the apical fixed suture. After that, go from the corneal side, then enter at the base of the limbus, enter through the scleral flap, then 3 throw is performed, a slip knot is created, and flow is adjusted, then excess end is cut, and outer end is cut flush with the cornea to prevent any windshield wiper effect. So this is the releasable suture in the place. This end is well buried in the corneal stroma, and this is the thing where you are going to release the suture. Now the question is whether you will put 1 suture or 2 suture. So first put the first suture and check the flow rate by irrigating the AC. If you think that flow is high, then you can put the second suture. But if the flow is less, then you have to loosen the slip knot. Now when to remove the releasable suture? It depends upon your IOP, blame morphology or antimetabolites used. So when the wound and anterior chamber are stabilized, the suture can be removed serially. Don't remove both the suture at the same time, and you can use digital ocular compression as a rough guide. And window period for suture removal is 2 weeks, and when you are using antimetabolites, this window period is more. So how to remove the suture? It is done under the slit tape under local anesthesia, and here you have to pull the suture. Suppose it is epithelialized, then you have to divide the cornea and then pull it slowly. And in case if the suture breaks, then obviously you have to go for the laser suturalalysis. Now after removal, you can see the bleb forming here. So what to look after suture release? Don't just send the patient home after releasing the suture. You can land in problem. The patient can have hypotonia or anything. So if the IOP is low, recheck the IOP after 30 minutes to see if it is lasting. If the IOP is unchanged, then you can try digital pressure to initiate or promote filtration. And if it's occurring, you can send the patient with advice for home massage. And follow up the patient next day also. Now complications are very minimal. It can be released, there can be difficulty in releasing the suture. And if the suture is not buried properly, then can be windshield wiper keratopathy. And leakage can occur through the needle track at the limbus due to shearing states. So post-op you should give antibiotics also. Now, points to be kept in mind is that one suture should be removed at a time, and IOP antechamber should be checked immediately and after 30 minutes. And if the suture is not removed, then trim the suture. Now, this is a meta-analysis. If you see, with relegible suture and without relegible suture, results are same, but trabeculectomy performed with relegible suture were better tolerated than without relegible suture. So, to conclude, this is a better technique than conventional trabeculectomy. Results are good in terms of post-operative complication, and such techniques should be followed in our day-to-day practice. These are my references. Thank you.
Very well spoken, madam. What is your experience with this releasable sutures? Do you do them regularly or based on case-to-case selection?
I put in all patients, do in all patients.
I also used to do in all patients, but sometimes what happens is if the patient is not going to be coming for follow-up, in those cases, if they don't get removed, then they may get a small debris collection at that side. And there onwards, I modified my own technique, and sometimes I say that no, let us not do the releasable sutures, because releasable sutures have to be
that has to be like kept in the mind while seeing the patient also, like whether the patient is coming. I'm a private practitioner, so the patient mostly...
Your patients will always come to
they
you.
will come for follow-up.
So you will not miss them
exactly.
for the others. And another thing is that if we are not doing for all cases, then how to say that yes, in this case I really need to do the releasable suture?
Where there is chance of like post-op AC swelling is more like in case of angle closure disease, it is best to put the suture definitely. At least one releasable suture should be there. Like when you suspect that post-op there can be SC swelling or hypotony is a possibility, then you should put a releasable suture, I feel.
And I feel that during the surgery itself, sometimes we get to know with with a average inflation pressure, whether the AC is maintaining or there is a tendency to shallow. In those cases, if we have to put additional sutures beyond one, then better be releasable sutures.
Actually, I was trained like that, so like from the starting, I am putting the apical suture and two releasable from the start.
That's great.
What is your experience of hypotonia after the releasable sutures? After releasing the
After
sutures?
releasing the suture.
Instances where hypotonia occurred and didn't
Actually, in
able-
my practice, I have never seen this, but while doing fellowship, when I was doing fellowship, I released one releasable suture, and the next moment, cornea was like saucer shape. It was touching the iris. So I immediately called my consultant, and she told me nothing to worry, just make the patient sit in the OPD and patch the patient. So after 1 hour, when I opened the patch, the AC was well formed. Then I didn't remove the second releasable actually.
So
it was
that,
the first post-op day.
Timing of removal of the suturing
is
is
also important.
most important. If at all we have to remove them, better to remove within 3 weeks or 4 weeks. Beyond 5 weeks and 6 weeks, it is being removed only to prevent infection.
Yeah, beyond 5 weeks, there is no point in removing this thing, just treatment.
And if mitomycin, then we can have the efficacy
6 weeks you can like
for somewhat longer duration.
Yes.
Okay, very nice.
Thank you.
Thank you.
Now the next talk is by Dr. Ravindra. Reviving the bleb, the right time to do the needling.
Thank you. Actually, this is a procedure that very few of us may be doing. How many of us have really done needling? Very good. Now I think after this talk, more of us will be doing the needling, because we often have blebs that are failing. And whether we should be really going for a new procedure or whether we should be trying to revive the procedure is the question that is top on our mind. And believe me, this needling is something that I started doing around 2014. And from then onwards, the need for repeat trabeculectomy has really come down. So, the timing, the procedure selection, and the risk benefit, all these things are most important. So, preoperative considerations, diagnosis of failing bleb. Then the next step is early intervention, then whether to do surgical needling, whether special situations like Ologen are available, are being faced by us, And with surgical needling, whether it is ab interno or ab externo, is also important, and use of surgical gonio lenses is also important. I don't think I'll be dealing with all the questions related to this. First, the basics on outcome. So we expect the trabeculectomy to work. If it works or not, we will tell the patient. We will be coming to know by the end of 3 months. Like cataract surgery, we say 1 week or 10 days or 15 days. But for trabeculectomy, we will say 3 months, and there may be need for multiple injections also. And then only we will be able to tell that, yes, this procedure has worked or not. So we are also going to be discussing that guarded filtration procedure is good from point of view of safety, but that for success to improve, we may be using mitomycin, 5-fluorouracil, and steroids for the longer duration, and needling. So this is also another depiction of the same thing. Before going for a repeat trabeculectomy or a revision of the trabeculectomy, we have this needling and antimitotics. So if the trabeculectomy is successful, IOP is below target, then yearly reviews, and then if target is maintained, okay. If target is not maintained, rise in IOP is there, then we may have to go for the needling. So either in long duration or in the immediate within 3 to 4 months also, we may have to do the needling. So before that, digital massage will be there, releasable sutures will be there, injection of 5-fluorouracil or mitomycin C will be there. So digital massage is something that we will be employing as a procedure within 10-15 days, but once the scarring has become more, this will be somewhat ineffective. So when it comes to needling, we have to look at features like extent of bleb, height of bleb, vascularity, and then based on those factors, we have to decide about whether we can go for 5-fluorouracil injection or mitomycin. So in case of high vascularity, we can use 5-fluorouracil injections, 2 per week for some days, some injections, or mitomycin injection subconjunctivally. Overview of literature, yes, prospective studies are there, but and retrospective studies are there, but randomized controlled trials are not there for this particular topic. So what happens with needling revision of blebs, ophthalmology 2008, and what happens with late needling of flat filtering blebs with adjunctive mitomycin C, 2011 article. Overview of the results. The factors that are important to consider are the duration. If it is long duration, means the trap was done sometime in the long distant past, the inverse effect is there. So chances of success will be less. But definitely, yes, success chances are there and it has to be considered. Bleb vascularity, more the vascularity, more the chances of success, because more the need actually. Okay, height is more than directly proportional, and more the number of needlings means some factor is there that is not being dealt with, and so chances of success are less. Now with the selected success rates, we are seeing 91%, 84%, 64%, 45%, and some articles are referring to it as 13%. So there is a wide range, but it only means that each individual surgeon has to customize the technique, and then they can see very good results in some cases, and some cases they may be able to. Then the complications are similar to trabeculectomy. What happens is that mild hyphema is there, or shallow anterior chamber may be there, or serous choroidal detachment may be there, mild vitreous hemorrhage, punctate keratopathy, transitional edema, all these factors could be there. And then the alternate methods may have to be used. Now, a flow chart on needling. So, we have to decide whether the duration is right. We have to look at the bleb features. We have to look at the gonioscopy. The gonioscopy is important because if we have to do needling, we have to be sure that the ostium is open. If the ostium is not open, it is better to go for a repeat trabeculectomy at a different site. So this cycle can go on. Trabeculectomy is done, digital massage is given, suture management is done, 5FU, needling, and then again, if it is failing, we can do the same. And
Sir, time.
that's time up for me, and I think topic is also done for me. Thank you.
Our Dr. Kiranmani, are you ready? Please come.
Good afternoon, everyone. Today I would be talking on an approach to anti-glaucoma medication allergy. This is most commonly encountered in any glaucoma practice. So this is a clinical scenario of 64-year-old male who has glaucoma since 5 years. He presented with pain, redness, itching and watering since 3 months. He has shown elsewhere and was diagnosed as viral conjunctivitis and was put on moxifloxacin eye drops, loteprednol eye drops, and he has been using this since 3 months. His intraocular pressure is under control with a fixed dose combination of timolol and brimonidine. Fundus showed 0.8 cup disc ratio with correlating visual field defects. So this is a clinical picture where there is conjunctival congestion and follicles. If you note that the congestion is predominantly in the inferior fornix when compared to superior fornix. This is the other eye of the patient. And when you take a closer look around the ocular adnexa, you see lid skin excoriation and lichenification, especially in the area where the anti-glaucoma medication has been spilled after instillation. So the first closest DD of this would be viral conjunctivitis as was treated elsewhere. So what are the points against viral conjunctivitis? Viral conjunctivitis is generally not of 3 months duration. It's generally of short duration, and there will be congestion and follicles in both upper as well as lower tarsal conjunctiva with or without pseudomembranes. So the points in favor of anti-glaucoma medication allergy are: first, we need to elicit a history of which anti-glaucoma medication the patient is using. There will be itching and burning sensation after the instillation of the eye drops. Follicles will be predominantly in the inferior fornix compared to the superior fornix. So there will be asymmetry in the congestion. Congestion in the inferior conjunctiva will be greater than superior conjunctiva. In some cases, there may be chemosis and diffuse hyperemia. And you also have to look around the ocular adnexa to see if there is any lid skin excoriation and lichenification. So mechanism by which the drug acts on conjunctiva, there can be complete tolerance to very severe involvement as seen as cicatrizing conjunctivitis in pseudopemphigoid. There can be anaphylactic or allergic acute or chronic conjunctivitis as seen in type 1 hypersensitivity. There can be contact allergic dermatitis as seen in type 4 hypersensitivity. So the adverse effect may result from either the main agent or the drug vehicle. Clinical presentation of AGM allergy varies from skin manifestations, lids, conjunctiva, cornea, lens and retina. So there can be lid skin excoriation and lichenification. There can be lid margin keratinization in severe cases, especially where there is cicatrizing conjunctivitis. Then there can be punctal stenosis. There can be non-specific conjunctival hyperemia. follicular reaction, and in severe cases as in cicatrization, you can see subconjunctival fibrosis, phoneal shortening, symblepharon, zipper-like scarring, ankyloblepharon with keratinization. On cornea, you can see superficial punctate keratitis, and sometimes ocular surface is bad, and there can be corneal and microbial ulcers, pannus. So the management mainly is two-pronged. One, you have to treat the adverse effects and also control the intraocular pressure. So first we have to identify the offending drug. We have to stop the offending drug. AGM allergy does not resolve until we stop the offending drug. And we need to take care of the ocular surface with lubricants and lid skin with skin emollients such as coconut oil or Vaseline petroleum jelly or any moisturizer to the lid skin. The inflammation should be controlled with topical steroids. So after treating the signs of toxicity, what is more important is to treat the intraocular pressure. So we should preferably, after stopping the offending agent, we can add oral acetazolamide to buy time to reduce the intraocular pressure. Once the allergy is little bit better, we can switch to another class of preferably preservative-free medication. If the pressure is not getting controlled with anti-glaucoma medication, then we will go for surgery based on the conjunctival health. So in scenario 1, where the patient is on AGM, either one medication or one combination medication, and the pressure is uncontrolled, it is not a big problem because we can stop the offending drug, give a Dimox cover and supportive treatment. Once the allergy is little better, we can restart on different medication. But in scenario 2, where the patient is using multiple medications or on maximal medical therapy, it is difficult to identify which drug is causing the medication. So we preferably stop all the medication, give oral acetazolamide cover, give supportive treatment. Once the AGM allergy is little better, we will reassess the allergy and intraocular pressure and restart a different drug or a different combination therapy, eliminating the drug which is most likely causing allergy, either brimonidine or brinzolamide or dorzolamide. If the IOP is under control, we continue the same drug. If IOP is not under control, we can consider the surgery once the eye is quiet. Based on the conjunctival health, we can decide whether we want to do a trabeculectomy or an implant. So coming back to our patient, once the offending drug is stopped and supportive treatment is given, the anti-glaucoma medication has decreased over a period of 2 to 3 weeks. So the take clinic message would be, anti-glaucoma medication allergy is often underdiagnosed in early stages due to failure of recognition. Suspect anti-glaucoma medication toxicity in case of non-resolving chronic follicular conjunctivitis. A careful drug history and clinical evaluation aid in diagnosis. Stopping the offending drug is mandatory. Remain vigilant about ocular surface in patients on long-term AGM. Reducing the preservative load improves compliance, and prefer a fixed dose combination over multiple drugs and bag-free formulations. Thank you.
Is the skin manifestations also come down?
Yes, sir. But they would take little longer time.
Just one person is remaining. We can just run through the slides if he is ready. Yeah. Sai Yashwant? Because his topic is important, most people are waiting for him. Yeah, we will be cutting down. Yeah. Yeah.
Actually, my laptop got shut down suddenly. It got repaired just now. Sorry for the delay, and thank you, judges, for giving. Okay. Yes, doctor. Good afternoon, everyone. My topic was on micro or minimally invasive glaucoma surgery. So it's an ab internal micro-incisional approach, and it's a minimally traumatic to the target tissue with a negligible disruption of normal anatomy and physiology, which is there is a modest efficacy will be there and a high safety profile will be there, and there will be a rapid recovery with minimal impact on the patient's quality of life also. So what fits for our patient will be the choice for a given surgery will be influenced by patient's prior surgical experience and trust in the surgeon, surgeon's experience and success with certain procedures and techniques that lead to the safety and success. So mainly this MAGS will be useful for the open angle surgeries than the closed angles. So trabecular outflow surgery, it can be in the trabeculectomy by internal approach like trabectomy, you are using the GATT, and by using the trabecular microbypass by stents like iStent and Xen gel stent you can be using. So mainly coming to the trabectome, it's an electrocautery device using the internal approach. It ablates the section of trabecular meshwork, unroofing the Schlemm's canal and collector channels. But the main advantages with this of trabectome will be it opens a continuous pathway from anterior chamber to Schlemm's canal. No conjunctival scarring will be there, but disadvantages will be cleft may close with forming the PAS, and access to Schlemm's canal circumferential is limited. And when coming to the GAT, favorable results can be seen in the pigmentary pseudo-exfoliation glaucomas or failed GDDs and steroid-induced glaucomas or angle restriction also sometimes, but it was contraindicated if there is any peripheral anterior synicase or aberrant angle vessels. But the complications from the GAT will be the hyphema, cyclodialysis and iododialysis, but recovery is seen in mostly 90 to 95% of patients within 1 month time also. And when coming to the excimer laser trabeculotomy, it's energy of the xenon chloride pulsed excimer laser connected to the quartz fiber optic probe. This procedure intends to enhance outflow facility by creating a micro perforations in the trabecular meshwork and inner wall of the Schlemm's canal. So 8 to 10 laser punctures are spaced over 90 degrees and each pulse delivering a mean energy of 1.2 millijoules over 80 nanoseconds duration. So coming to the eye stent, it was approved and used in a combination with the cataract surgery also for mild to moderate open angle glaucoma surgeries, and the ideal candidate should be stable and well controlled disease to reduce dependence on the topical medications. It's a 1 mm into 0.3 mm only and weights is just a 60 microgram and heparin coated also to prevent fibrosis and blockage. And the main mechanism is designed to improve the aqueous outflow through the natural physiological pathway, and it creates a bypass through the trabecular meshwork to the Schlemm's canal. And CyPass is a suprachoroidal shunt. It's a 6.35 millimeter long and had a single lumen of about 300 mm. And aqueous can enter the distal lumen residing into the anterior chamber and pass into the suprachoroidal space through the multiple fenestrations along the length of the implant. And obstruction and encapsulation are the possible sources of the failure of the CyPass. And what are the IOP goals? Actually, patients with target IOP goals of low teens might be able to get this goal with MAGS and the medications, and glaucoma suspects and early open angle glaucoma patients that will rapidly progress but who also have a cataract can be considered for phaco alone or phaco with MAGS. So in a study by the Philip et al., if we give a patient early enough, a MAGS helps to prevent being on too many drops or to even avoid starting the drops also. So for more severe cases of glaucoma, MAGS does not routinely get eye pressures into the low teens, and in those patients, patient need pressures in low teens to high single digits of glaucoma progression to halt. This MAGS will be helpful. So what after the MAGS? So paradox was there to prolong attempt at a medical control in these eyes because they were thought to have a lower risk of visual field deterioration. If you put off necessary surgery, patients get worse. So MAGS can definitely fill a role in the early stages of diseases for controlling the pressures. And a patient controlled for 5 years with MAGS procedures who then goes on to receive a trabeculectomy can probably get through her lifetime without significant vision loss, and options are more limited if trabeculectomy is done earlier. And some complications are there which include the bleeding in the eye, temporary complications like IOP rise or corneal swelling, visual disturbances may also be there as a complications. And coming to the conclusion, the advent of MAGS has allowed for improvement management of patients with mild to moderate glaucoma. As surgeon experience expands and number of MAGS approach grows, these procedures may even be utilized in more severe cases and across a wide range of clinical scenarios. And the field of MAGS has expanded rapidly in the last decade, adding to the glaucoma surgeons' armamentarium and their ability to tailor surgical procedures to each specific patient. Future devices and surgical approaches will continue to be developed in the coming years. Thank you. Thank you, Judge. Thank you, everyone.
Thank you very much. If speakers can come, we will have a group photo.